In this video, we will discuss how to manage the diabetes in Ramadan and what are the modifications which are required in the dosage of different drugs to make the fasting safer for the patients. So as you know that fasting during the Ramadan is one of the five pillars of the Islam, and fasting is obligatory for all the healthy Muslims who have reached the puberty. But Islam has made certain exemptions for those who are suffering from different types of the medical diseases, but still it is ultimately the choice of the patient whether to fast or not to fast. But as a healthcare physician, our responsibility is to make the fasting safer for them. So before moving ahead, we will discuss the certain facts about the epidemiology of the diabetes. In 2019, the number of people living with the diabetes was estimated to be 463 million people. And among these, 190 millions are the Muslims, and among these 190 million, 4 out of 5 Muslims have intention to fast during the Ramadan. So, considering that many Muslims living with the diabetes are deciding to fast during the Ramadan, the need for evidence based practical guidance is greater than ever. So, briefly, we will discuss what are the benefits of the fasting. Fasting may help to lose the weight, it may improve the HbA1c level, blood pressure control, cholesterol levels, it may also improve the outcome of fatty liver disease. But these benefits are not for the everyone, and certain risks are also associated with the fasting. These risks include hyperglycemia, hypoglycemia, dehydration, thrombosis, and increased risk of the DKA. The primary objective of this presentation is to prevent these complications, particularly the hypoglycemia, which is the life-threatening complication of the diabetes mellitus. So, as a healthcare physician, you must know what are the patients which are at increased risk of developing these complications. So, for that purpose, we do the pre-Ramadan assessment, which should be done 6 to 8 weeks before the start of Ramadan. So, during the pre-Ramadan assessment, a healthcare physician must take a thorough medical history. He should perform the thorough clinical examination, and he should do the relevant investigations to evaluate the certain parameters. And actually, there are 14 parameters which we will evaluate during the pre-Ramadan assessments. So these parameters includes what is the type of diabetes, what is the duration of the diabetes, whether the hypoglycemia was present in the recent past or not, what is the level of the glycemic control, and which type of treatment the patient is taking, whether he is taking the oral hypoglycemic drugs or the insulin, whether the patient is able to self monitor the blood glucose levels, whether the patient has any kind of acute or the chronic complication of the diabetes mellitus, and whether the patient is pregnant or not, and what is the level of the cognitive function of the patient, and what is the occupation of the patient, and what is the previous Ramadan experience, and of course the fasting hours. So based on these parameters, we categorize the patient into the three categories: red category, yellow category, and the green category. For each category, the medical and the religious recommendations are there. For example, for those who are falling in the red category, the fasting is not recommended. And for those who are falling in the green category, who has this score 0 to 3, the medical recommendation is that fasting is safe, and the religious recommendation is fasting is obligatory for those who are falling in the green category. And For those who are falling in the yellow category, the fasting is safety is uncertain, and the religious recommendation for these groups of the patient is that the patient have choice whether to fast or not to fast. So you should respect the opinion and the decision of the patient. Now, after the thorough clinical assessment, the next step is also very important. You should educate the patient in which category they fall, what are the complications which can happen during the fasting, and you should also educate the patient the increased frequency of self-monitoring of blood glucose is required during the fasting, and you also have to remove the misconceptions regarding the skin prick does not break the fast, and also the insulin injection during the fasting does not break the fast. So the frequency of the blood glucose monitoring is actually individualized. You have to do the individualize. You have to make the changes for every patient. For example, for those who are at high risk, increased frequency of blood glucose monitoring is required. And for those who have the their diabetes well controlled, in that group, you can advise only 3 times monitoring of the blood glucose. So particularly we advise to monitor their blood glucose level 2 hours after the Sahri, 2 hours before the iftar, and 2 hours after the iftar. So it is also very important to educate the patient about when to break the fast. So anytime if the patient has symptoms of hypoglycemia or the hyperglycemia or the dehydration or any acute illness occurs, then they can break their fast. And if at any time the blood glucose level falls below 70, they can break their fast. And if the blood glucose level is between 70 to 90, then they should recheck their blood glucose after 1 hour. But if the blood glucose level are greater than 300 milligram, then you should ask the patient about the symptoms of hyperglycemia, and you should also do the urine complete examination to check for the ketones. So if the ketones are present or if the symptoms of hyperglycemia, then the patient can break the fast, otherwise they can continue their fast. Now let's discuss what modifications are required in the dosage of different drugs. Remember that for those drugs which are associated with decreased risk of hypoglycemia, dose modification is not required. So, first we will discuss metformin. As you know that metformin is associated with low risk of hypoglycemia, so dose modification is usually not required. If the patient is taking the metformin once daily, he should take at iftar. If the patient is taking the metformin twice daily, he should take the same dose at the iftar and the sahur. But if the patient is taking metformin 3 times a day, he should take morning dose at sahur, and he should combine afternoon plus evening dose and should take at the time of iftar. In case of prolonged release preparation, still no dose adjustment is required, but the patient should take this dose at the time of iftar. Now, the next drugs are the sulfonylureas. You know that sulfonylureas are associated with increased risk of hypoglycemia, and among the sulfonylureas, glibenclamide, which is the older generation sulfonylurea, has been associated with highest risk of the hypoglycemia. About 26% of the patient they develop the symptomatic or asymptomatic hypoglycemia. And even lowering the dose of glibenclamide does not decrease the incidence of hypoglycemia. If the patient is taking the sulfonylurea, which are the older generation sulfonylurea, for example, the glibenclamide, the, the best thing is that the glibenclamide should be stopped. Now the patient can be shifted into the newer generation sulfonylurea or any other group of the anti-hyperglycemic drugs. For example, if the patient is taking the modern sulfonylureas once a day, then he should take the usual dose at the time of the iftar. But in the case of twice daily dosing, the iftar dose remains same and the suhoor dose should be reduced by 25 to 50%. So the next drugs are the DPP4 inhibitors. So you know that DPP4 inhibitors and the GLP-1 analogs work by increasing the insulin secretion, but this secretion of insulin is the glucose dependent. Whereas in case of sulfonylurea, insulin secretion is not glucose dependent. So DPP4 inhibitors and GLP-1 analogs are associated with low risk of hypoglycemia. So no dose modification is required, but you should take the same dose at the time of the iftar. Now studies shows that both the sitagliptin and the vildagliptin have low risk of hypoglycemia and they were equally effective, but vildagliptin is more effective in improving the HbA1c levels. And as I have already talked about, the GLP-1 analogs are associated with the low risk of hypoglycemia, so no dose adjustment is required. But another additional benefit of the GLP-1 analog are that is that they also decrease the gastric emptying. They also decreases the appetite. So you can say that fasting might be easier for those who are taking the GLP-1 analogs. But as you know that GLP-1 analogs are very expensive, so you should not prescribe these drugs just for the sake of decreased appetite. The next group of drugs are the SGLT2 inhibitors, which are also commonly used drugs these days. So they are also associated with low risk of the hypoglycemia, so no dose adjustment is required, but the dose should be taken at the time of the iftar. Why? Because SGLT2 inhibitors, they causes the diuresis, so there will be increased risk of the dehydration. So you should advise the patient that increase your water intake in the non-fasting hours. And if the patient is taking the loop diuretics or if the patient is having the renal impairment, so you should not advise these SGLT2 inhibitors in this population. And if you are starting the SGLT2 inhibitors, they should be started at least 1 month before the Ramadan. Now, TZDs are also very safe drugs. They have low risk of the hypoglycemia, so no dose adjustment is required in case of the TZDs. So if the patient is taking the combination of the drugs which are associated with the decreased risk of hypoglycemia, for example, empagliflozin plus metformin or vildagliptin plus metformin, still no dose modification is required, but the dose should be taken at the time of the iftar rather than in the morning. So now the insulin. You know, insulin is associated with very high risk of the hypoglycemia. So dose adjustment should be done in both the type 1 diabetes mellitus patient and in type 2 diabetes mellitus patient. And remember that insulin analogs are recommended over the conventional human insulin preparations because insulin analogs are associated with decreased risk of the hypoglycemia. The basal bolus regime is recommended in the patients, particularly for the type 1 diabetes patients. So in the basal bolus regime, if the patient is taking the basal insulin once a day, the dose should be reduced by 15 to 20%, and the dose should be taken at the time of the iftar. For example, if the patient was using glargine 10 units at night, then in the Ramadan, the dose should be reduced by 15 to 20%. Now the patient should decrease its unit by from 10 to 8 in order to prevent the uh, risk of the in order to prevent the development of the hypoglycemia. Similarly, if the patient is using the basal insulins twice daily, then the morning dose should be reduced by 25 to 50%. The basal insulins are safe as compared to the short-acting insulins. Why? Because the basal insulins don't have the peak in their profile, so they are associated with low risk of the hypoglycemia. So in the basal bolus regime, now how to adjust the short-acting insulins? So in the short-acting insulin, sahur dose is reduced by 25 to 50%, and you should omit the lunchtime dose. The evening dose remains the same. And if the patient is using the pre-mixed insulins, then the evening dose would remain same, whereas the whole dose should be reduced by 25 to 50%. Now the dose titration is also very important. You should educate the patient how to titrate the dose. The dose titration should be done on every third day. So how to titrate the dose? For example, if the patient is using the basal bolus regime, if the blood glucose levels fall below 70 anytime during the day, then they reduce the dose by 4 units. Then the further adjustment can be done according to the blood glucose levels. Whereas in case of short-acting insulins, the evening dose would be adjusted according to the pre-sahur blood glucose level, and the morning dose of the insulin would be adjusted according to the pre-iftar blood glucose level. Similarly, in the case of the pre-mixed insulin, the pre-iftar dose would be adjusted according to the pre-sahur blood glucose level, and the pre-sahur insulin is adjusted according to the pre-iftar blood glucose level. For example, if the pre-sahur blood glucose was less than 70, then in the next day you should reduce the dose of the pre-iftar insulin by 4 units, and then the further adjustment can be done according to the blood glucose level as shown in this figure. So